colorectal session in the surgical gastroenterology series. And I'll be taking on the colorectal part 1, which I'll be covering on the basic anatomy and other non-malignant part of the colorectal. And Dr. Kanchan will take care of the malignant part of the colorectal. Fine. And mainly the scope of the class will be anatomy and the physiology of colon and rectum, rectal prolapse, colonic bleeding, ischemic colitis, diverticular disease of the colon, volvulus, large bowel obstruction, including pseudo obstruction, and inflammatory bowel disease. Malignancy will be taken by in the next class by Dr. Kanchan. And the other common anorectal condition which you have routinely seen and managed during your residency, like fistula, fissure, hemorrhoids, and constipation, will be given as MCQs in the subsequent test, which will be giving the next week. Okay. So some of the important points in the anatomy, I'll cover the basic aspects which is given in the standard textbooks, which both in Saveston and Shackelford. Some of the important aspects, both clinical as well as for exam-oriented MCQ points. So if you take the anatomy of the colon, let's start with some basics. So the colon starts from terminal ileum, so the cecum. So some of the dimensions which you might have to remember is the cecum length is only 10 centimeter, and the diameter of the cecum is 7.5 centimeter. Okay, so the diameter of the cecum is important because cecum is the most capacious part of the colon, and the diameter is around 7.5 centimeter. As in case of any obstruction, like in a distally, either in the transverse colon or in the left side of the colon, what happens? The cecum dilates because it is thin wall and it is more capacious. So there is a critical diameter up to which the cecal diameter is monitored for. The critical diameter is of the cecum is around 12 centimeter. So more than 12 centimeters seen in X-ray or CT, the diameter of the cecum, I mean. The diameter of the cecum more than 12 centimeters seen in X-ray or CT means the cecum can go in for gangrene and it might go for a perforation. So you should be very careful. Say anything more than 12 centimeter of a cecal diameter, either in a mechanical obstruction or even in pseudo obstruction, you should be very careful and should think of some definitive surgical procedure in the, and decompression. Okay. The cecum length is around 10 centimeter and the diameter is 1.5 centimeter. I also told about the critical diameter in which you have to intervene surgically, either in mechanical or pseudo obstruction, which is 12 centimeter. Which is 12 centimeter. I mean, the 12 centimeter is a diameter, which is measured by either a CT or by a standard X-ray. So next, the ascending colon. The ascending colon, the measurement is 15 centimeter. Then the transverse colon is around 50 centimeters. Is the largest part, is the longest part, followed by descending colon is around 25 centimeter, and the sigmoid colon is 40 to 45 centimeter. Also note that, so some other basic point is only the transverse colon as well as the sigmoid colon has a mesentery in the form of transverse mesocolon and the sigmoid mesocolon. Fine. Okay. So also the next point is the cecum maximum caliber is 7.5 centimeter, as I told before, and sigmoid colon is the narrowest part of the colon. The diameter is around 2.5 centimeter. Fine. Also, we can see in anatomy of the colon, we can see some longitudinal bands in the colon. These longitudinal bands are called tinea coli. So there are 3 longitudinal bands seen in the external aspect of the colon, and they are named as tinea mesocolica. So tinea mesocolica means the mesocolon gets attached to that longitudinal band, and they also extend to the other part of the colon till the sigmoid descending colon, sigmoid colon. And at the point at the rectosigmoid junction, all the 3 tinea coli merges together. Fine. So the rectum is a part where you don't find any tinea coli or appendices epiploicae. Fine. So in the external aspect of the colon, we have 3 longitudinal bands which are called the tinea coli. And the tinea coli can be named as, these 3 tinea coli are named as either tinea mesocolica, in which the mesocolon is attached, tinea omentalis. Tinea omentalis is this part of the tinea where the omentum gets attached, and the tinea libera is the other longitudinal band. Okay. So the tinea is more prominent in the transverse colon. That is, all these 3 longitudinal bands are very prominent in the transverse colon, and that is why in the transverse colon it has a very triangular configuration when you see it on a colonoscopy. So this is the colonoscopy in which if you see the lumen will have a typical triangular configuration, which is a characteristic feature of a transverse colon. That's because of the presence of 3 prominent longitudinal bands of tinea. Fine. So the measurements you keep in mind, and the most important is the cecum diameter is normally 7.5 centimeter, and the critical diameter is 12 centimeter in which you have to intervene. Okay, fine. So the next part is the internal aspect of the cecum. You find two openings. One is obviously, there's an appendicular opening. The other is the ileocecal opening. So basically what does is it slows the transit of food contents from the ileum to the cecum. So whether it prevents the reflux, it is unknown, but the definite thing is it slows the transit of contents from the ileum to the cecum. So it basically has it's a semilunar in shape with the two crescentic folds with a frenular appearance. This is a cecal wall. The other important thing is, so this is the colon. If you see the cross section, you find stalks of fat attached to the colon. These stalks of fat are called appendices epipleucae, as seen in this picture. So these are all the appendices epipleucae, the stalks of fat attached to the colonic wall. Fine. And so this this 1, 2, 3, these are the longitudinal bands which are called as tinea coli. And in between the tinea coli, you can find the marginal artery coming closer and forms a vasa recta. And between the tinea coli, they pierce the colonic wall and supply the colonic musculature. The most important part is the part where the vasa recta pierces the colonic wall. This is the part where the colonic wall is weakest, and that is the part through which a condition called diverticulosis can happen. Okay. So appendices epipleucae, they are stalks of fat enveloped by peritoneum attached to tinea libera, and they are very pronounced in sigmoid colon. Okay. So the next anatomical important aspect is the sigmoid colon anatomy. Always remember, sigmoid colon, as I showed before, is again, apart from transverse colon, this also has an attached mesentery. And sigmoid colon, as I said before, the length of the sigmoid colon is 40 to 45 centimeter, and the mesentery of the sigmoid is attached in a V-shaped manner. So this is the V-shaped mesentery of the sigmoid colon, and the apex of the V is goes towards the left iliac fossa, towards the left iliac vessels. Fine. So this is the apex of the V. It goes to the left iliac vessel, and between the sigmoid colon and this is the posterior retroperitoneal aspect, there is a recess. This is called intersigmoid fossa, in which you can find intraoperatively the left ureter. So the intersigmoid fossa is important anatomical landmark for identifying the left ureter before doing any left-sided colonic surgery. Fine. So the sigmoid colon is the most muscular portion of the colon, and it has the ability to generate the highest intraluminal pressure. And that is why the sigmoid colon is the most common site for diverticulosis. Fine. So regarding the blood supply of the colon is very important. So the blood supply, if you start from the basics, so it's a colon has derivatives both from the midgut as well as from the hindgut. Therefore, the blood supply is from both the superior mesenteric artery, which is the blood supply of the midgut, and the inferior mesenteric artery, which is the blood supply of hindgut. Fine. So if you see the blood supply, if you will summarize from the basics. So this is the superior mesenteric artery. If you see the superior mesenteric artery, it originates from the aorta. It's one of the ventral branch of the aorta at around L1 from the inferior border of pancreas, and it supplies the colon from the branch which arises from the right side. So most of the branches, all the branches which supply the colon will arise from the right side of the SMA, because the left side of the SMA arises all the jejunal and ileal branches or small intestinal branches. So this is the SMA. So the first branch which comes off from the SMA is the middle colic artery, and the middle colic, as it comes, it divides into a right as well as a left branch. So then after the middle colic, then comes the right colic artery. This is the right colic artery which gives into ascending branch, which anastomoses with the right branch of middle colic, and a descending branch which anastomoses with the ascending branch of ileocolic. So the next branch will be the ileocolic artery, which has an ascending branch which anastomoses with the right colic, and further the descending branch goes and divides into an anterior cecal, posterior cecal, appendicular artery, and some terminal ileal branches. So basically, all these branches from the SMA supplies the terminal ileum, cecum, ascending colon, as well as the transverse colon. Fine. So what are these branches? The first branch from the SMA, which includes the middle colic. The next is the right colic, and the next is the ileocolic arteries. Okay, fine. So next comes the IMA. So IMA is this branch. So this branch is the inferior mesenteric artery. So inferior mesenteric artery originates approximately at the level of L3, around 3 to 4 centimeter from the bifurcation of the aorta, above the bifurcation of the aorta. Fine. So this IMA, as it comes from the aorta, it divides into a left colic artery. So this is the left colic artery, which anastomoses with the marginal artery, which is formed by the middle colic arteries, and it continues down as a superior rectal artery, and it also gives to the sigmoidal branches. So from the IMA, we get the left colic. Sorry, we get that this is the left colic. So from the IMA, this is the left colic. This is all the sigmoidal artery branches, 1, 2, 3. So we get around 4 to 6 sigmoidal artery branches. And then the IMA continues down as the superior rectal artery or superior hemorrhoidal artery. In addition, the blood supply of the rectum is also given by the middle rectal artery, which is a branch of the internal iliac artery, as well as inferior rectal artery, which is a branch of the internal pudendal artery, which is internal branch of internal iliac artery. Okay, fine. So the crux, the colon and rectum is supplied both from midgut and hindgut arteries, that is both from SMA and IMA, and the SMA is through supplies through branches like middle colic, right colic, and ileocolic, and the IMA supplies mainly the left side of the colon through the left colic, through the sigmoidal arteries, and it then continues and descends down as the superior rectal artery. Fine. So some of the important facts which you have to remember is, among the colonic blood supply, this ileocolic artery has the least anatomical variation. It is almost constantly and consistently present in all the patients. Right colic artery, as I said before, when I took the class on coloplasty, that left-sided colon is always much preferred, because the left colic artery anatomy is always very constant and consistent, and right colic anatomy is very variable. So the right colic artery anatomy is very variable, and it is absent in around 18% of the people. So 18% is given in Shackelford, and exactly 2 to 18% is the figure given in Savistton. Fine. So remember, ileocolic artery has a very least anatomical variation, and right colic artery has a very variable anatomy, and it is absent in around 18% of the people. Okay, the Savistton gives it as 2 to 18%. In addition, middle colic artery, also remember this figure, is absent in around 20%, and Savistton gives the figure as 4 to 20%. So always remember, both right colic artery and middle colic artery is absent in approximately 20% of the people, 20% of the patients. Accessory middle colic artery, that is, in addition to the normal middle colic artery coming out from the SMA, there is another middle colic artery which is present in around 10% of the people. Fine. Okay, fine, guys, are you with me? Can we proceed?
Yes, sir.
Fine. Okay. So apart from that, so I told you before, the right colic artery as well as the middle colic artery, the anatomy is variable, and approximately they are absent in around 20% of the people. The middle rectal artery, as I told before, rectum is supplied by 3 arteries. One is the continuation of the IMA, which is the superior rectal artery. The next is a middle rectal artery, which is a branch from the internal iliac artery. The next is the inferior rectal artery, which is a branch from the internal pudendal branch of the internal iliac artery. The most important is the middle rectal artery. When it branches off, it goes near the lateral ligaments. That's something called lateral stalks, which fixes the rectum to the pelvic wall. And middle rectal artery is absent in 40 to 80% of the patients. So middle rectal artery is it's not very commonly found during rectal dissection, but it's sometimes it can be encountered middle rectal artery, and we have to watch for this artery when we are dissecting the rectum along the lateral aspect. Fine. And remember, I told before, middle colic and right colic might be absent in around 20%, but here middle rectal is absent around 40 to 80% of patients. Fine. So I think this is clear about the artery of arterial supply of colon and rectum. So now understand this slide. So an important clinical aspect when coming to the high ligation versus low ligation for rectal cancer surgery. So what is this high ligation? What is low ligation? So the high and low is determined upon where you are ligating the IMA when you are doing a surgery for rectal cancer. So when you're removing the rectum for a malignancy, obviously you have to ligate the blood supply corresponding. Whatever organ you have to remove, you have to ligate the blood supply to that organ. So obviously for a rectum, when you're doing a surgery for rectal cancer, so the blood supply of the rectum is from the inferior mesenteric artery. So where you're going to ligate the inferior mesenteric artery is this debate of high ligation versus low ligation. So in high ligation, it is high because you ligate the inferior mesenteric artery close to its origin from the aorta. And in low ligation, you ligate the inferior mesenteric artery once it gives off the left colic branch. So what is the difference? High ligation, ligate the IMA close to its origin from the aorta. Low ligation, you ligate the IMA after the left colic artery is taken off. So why this debate of high ligation versus low ligation? Because if you do a high ligation, that is at this point, if you do a high ligation, what happens? A lot of sympathetic plexus are situated in the aorta, and if you do a high ligation, you might damage one of these nerves. And if you damage the sympathetic nerves, it might result in genitourinary dysfunction, erectile dysfunction, as well as a bladder dysfunction. So that is why the high ligation might result in sympathetic plexus injury, thereby resulting in bladder as well as genitourinary dysfunction. Whereas what is the advantage of doing a high ligation is, if you do a high ligation, suppose in a patient with a rectal cancer, you might have positive nodes in this high ligation that might result in increased lymph node yield and better clearance for if you're doing surgery for the rectal cancer. And the other advantage is, if you're doing a high ligation, the colon might be freed off so that you can take the colon for a very low anastomosis when compared to doing a low ligation. Understood? No? So to one disadvantage is you might injure the sympathetic plexus. Two advantages is you can increase the lymph node yield if you take off the lymph nodes that are present in this area. Number two, you can get an extra length of colon if you do a high ligation, with which you can easily do a low anastomosis deep inside the pelvis. That is the advantages and disadvantages of a high ligation. So what is the advantage of low ligation? Obviously, if you ligate at this point, so definitely you won't be injuring any of the sympathetic plexus, which is closely attached to the aorta. And so this is the part where you ligate in low ligation. So the same this figure gives here. So in specimen with a high ligation. So high ligation means, so this is how the specimen will be. So you take this entire rectum, sigmoid colon, and this if you do a high ligation, so this will be the specimen. If you do a low ligation, so the specimen will go off like this. Okay, the left colic artery will be preserved in a low ligation. Fine. So in low ligation, the extra advantage is you won't injure the nerve. And if you are doing a very high anastomosis, like a very anterior section where the tumor is above the peritoneal reflection, you can easily do an anastomosis even by doing a low ligation. But if you want to do a coloanal anastomosis, that is an anastomosis which is very low down inside the pelvis, only a high ligation can make the colon free, and it will give the extra length, and it will come tension free to reach deep inside the pelvis. So I think you understood about this concept of high ligation versus low ligation. Fine. So let's do this MCQ. Identify this false statement in rectal cancer surgery. Fine. High ligation involves ligation of IMA at the point of takeoff from the aorta. True or false?
True.
True. Okay, good. Low ligation involves ligation distal to left colic artery.
True.
True. Excellent. High ligation gives poorer lymph node yield.
False.
False. Yeah, obviously it's false. Sorry, I didn't take off that arrow. Fine. So high ligation, the main advantage of high ligation is, one, you will be able to clear the lymph nodes near the IMA area. Therefore, you'll get a better lymph node yield. And the other advantage is you will get an extra length, so that the extra length of colon will be freed down. And for anastomosis, which is deep down in the pelvis, high ligation is the best thing to do. Hypogastric nerve damage and genitourinary complication are high with high ligation of IMA. True or false?
True, sir.
True. Excellent. Fine. Just a minute. Fine. Next slide. So the next point is just 1 minute, guys. I'll just make a call. I'm getting a call from the what? Okay. Just a minute. Okay, so the next part is, guys, I'm back. So the collateral, regarding the collateral circulation of for colon. So this is a very important aspect because the colon has a very rich blood supply, and the collateral circulation of the colon is tremendous. That even if two or three arteries are blocked, the collateral circulation can take the blood supply which is needed in the blocked area. For this collateral circulation is mainly achieved by two of the important arteries. One is the marginal artery of Drummond, and the other is the arc of Raylan. So, what is this marginal artery of Drummond? So, what happens? So, this is the artery which is found along the antimesenteric border of the colon, and which goes along the ascending colon, transverse colon, and the descending colon, and it almost till the sigmoid colon. So, this is the marginal artery of Drummond. So, you can see the marginal artery of Drummond. Basically, it connects all the arteries of the colon, like ileocolic, right colic, middle colic, left colic, as well as the sigmoidal, as well as the suprarectal branches. So the most important aspect is, so even if one of the branches is blocked, like even if this right colic is blocked, what happens is through the marginal artery branches, ileocolic can supply the part supplied by the right colic. So one artery which is important for the collateral circulation in the colon is marginal artery of Drummond. So for example, even if the left colic is blocked through the marginal artery, the SMA can supply blood through the middle colic and the marginal artery of Drummond. So although this marginal artery of Drummond supplies, make sure the colon has adequate blood supply throughout the colon, there are two points in the colon in which there are watershed areas in which the blood supply is low, and in which is more prone for ischemia in any hypertensive episodes. So what are these 2 points? One is the splenic flexure area, and it is called as Griffith's point, and other is the rectosigmoid area. It is called the Sudex point. So from top to bottom, from up, the one which is at the top. So G comes first, then comes S in alphabetical order. So in the top is Griffith point, and on the bottom it is Sudex point. Okay, the Griffith's point is at the splenic flexure, and the Sudex point is at the rectosigmoid area. Okay. So the Griffiths point is the watershed area between the right and the left circulation, where the blood supply, even though we say the collateral circulation is well formed in the colon, these are the two weak points in which the circulation, even if it somewhat compromised, it may not be able to sustain the blood supply in these areas, and these are the areas which are more prone for ischemia and ischemic stricture in the future. Okay, so the next important artery which forms an important part in the collateral circulation is the arc of Raylan. It is also called as just a minute. Which is also called as, what is this? Yeah, which is also called as meandering mesenteric artery. Meandering mesenteric artery or central anastomotic artery. Central anastomotic artery. So these are the other two names of arc of Raylan. So where does this arc of Raylan originate, and what does it connect? So basically, arc of Raylan, in short, connects the proximal SMA. So this is the proximal. So basically, it connects the middle colic with the left colic, the proximal left colic. See this branch. So this branch is the arc of Raylan. So basically, it connects the SMA with the IMA, that is proximal SMA to the proximal INA. To be more precise, it connects the middle colic with the left colic, with the proximal left colic. So if the IMA is blocked, the main IMA is the IMA is the main supply of the colon. If the IMA is blocked, what happens? This arc of Raylan starts acting as a bypass route, and through from the blood supply from the SMA comes to the supply the IMA territories. Fine. So this is how the arc of Raylan plays an important point in the collateral circulation. This arc of Raylan is usually not seen. It's well appreciated only when at the SMA or IMA is blocked close to its origin. Fine. So marginal artery of Drummond, arc of Raylan, and the two watershed areas, Griffiths Point and Sudex Point, has to be remembered. Fine. So the venous drainage of the colon, obviously it's a part of a portal circulation, and the most of the right side of the colon, drains into the superior mesenteric vein. The right side of the colon drains into the superior mesenteric vein. The left side of the colon drains through the left colic vein, sigmoidal veins, and the superior rectal vein, which all drains into the inferior mesenteric vein, and inferior mesenteric vein in turn most commonly drains into the splenic vein. Okay. So what is the anatomical importance? Clinical anatomy in this part is the inferior mesenteric vein. Always you have to do a high ligation if you want to, if you're seeing if you're seeing a low anterior section or any rectal surgeries. The higher you ligate the inferior mesenteric vein, like I said, higher you ligate the inferior mesenteric artery, the same way, higher you ligate the inferior mesenteric vein, it will be easier to bring the colon, to mobilize the colon for anastomosing in the pelvis. So proximal ligation of IMV is always better for mobilization till pelvis. Fine. So lymphatic drainage of the colon. So basically the lymph nodes draining the colon are divided into 4 groups. So one is the epiploic group or epicolic group. So epicolic group is basically present in the colonic wall, and next is the paracolic group. Paracolic group is found along the marginal artery of Drummond, and then comes the intermediate group. Intermediate group is along the artery which supply the colon, and the main group or the principal group are present or close to the SMA or the IMA origin. Okay, there are 4 lymph node groups. Remember, epicolic in the bowel wall, paracolic, marginal artery of Drummond, intermediate nodes in the colic branches, and the principal or main nodes close to the SMA and IMA origin. Fine. Now come to the rectal anatomy. So rectal anatomy is very important because you need to understand this anatomy and the important for doing a better surgery with a good oncological margins, as well as with to follow good oncological principles. So the most important is, if you take rectum, there are you must remember how you divide the rectum. So divide the rectum. So it always roughly 0 to 7 centimeter. 0 to 7 centimeter is lower rectum, 7 to 12 centimeter is mid rectum, 12 to 15 centimeter is upper rectum. But recently, in oncological aspect, when you're doing an MRI classification of the rectum, so based on MRI, so how do you divide lower, mid, and upper rectum? 0 to 5 centimeter is lower rectum, 5 to 10 centimeter is middle rectum, 10 to 15 centimeter is the upper rectum. So this is how the recently rectal cancer, for what rectal cancer we follow only MRI rectal cancer staging, which helps us in deciding on the need of neoadjuvant therapy, which helps us to decide the treatment. And based on MRI, the rectum is divided into low, mid, and high based on this distance: 0 to 5, 5 to 10, 10 to 15. So this is the MRI. And this is roughly the clinical division of rectum: 0 to 7, 7 to 12, 12 to 15 centimeter. Remember, all these numbers are from the anal verge. These measurements are anal verge. We don't take rectum alone exclusively. We always include the anal canal along with it, forming a. We always take it as a complex of anorectum and don't take only rectum. Fine. So always when you take, the rectum is not completely covered by the peritoneum. You can see only the upper third of the rectum. If you divide the rectum into an upper third, middle third, and lower third, only the upper third of the rectum is covered by the peritoneum, both on the anterior aspects as well as in the lateral aspect. Whereas the middle third of the rectum is covered by peritoneum only in its anterior aspect, and the lower third of the rectum is completely extraperitoneal. So remember this: upper third of rectum covered by peritoneum both in the anterior and the lateral aspect. Middle third of the rectum is covered by the peritoneum only in the anterior aspect, and the lower third of the rectum is completely extraperitoneal and is not covered by peritoneum at all. So that is one point regarding the peritoneal reflections. Okay. So the next important point is, see this anterior peritoneal reflection. So this part between the rectum as well as the between the bladder is called rectovesical pouch, or it is also called as Douglas pouch. And here is the peritoneal reflection. So this peritoneal reflection, the distance which is given in subistern is 7 to 9 centimeter from the anal verge in men, and 5 to 7.5 centimeter from the anal verge in women. So remember this distance. Also, apart from this, I want to tell you this peritoneal reflections, which is commonly seen. If you take this rectum is enveloped by a visceral peritoneum, and that is called as fascia propria of rectum. So this rectum, as such, the rectal tube is enveloped in the in a peritoneal covering called fascia propria of rectum. Second, I think someone is not muted the mic.
No audios.
Just wait for a while. I'm calling you. Just wait. Just wait for a while. They are joining back.